Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Barry Stickney, a professor of hematology and internal medicine at the University of Kansas Cancer Center in the Division of Hematologic Malignancies and Cellular Therapeutics. He was the prior director of the bone marrow stem cell transplantation program at the University of Kansas Medical Center and has also had experience in the pharmaceutical industry developing new drugs and treatment programs for patients with myelodysplastic syndromes and acute myeloid leukemia. Dr. Stickney is involved in a number of studies for the treatment of MDS as well as AML and has been the author or co-author of numerous articles and abstracts on MDS and AML. He has extensive experience, having spent many years treating patients with MDS and AML. So with that said, it is my pleasure to introduce Dr. Stickney.
Good afternoon. I'd like to thank everyone for spending their Saturday afternoon listening to the talk on understanding lower-risk myelodysplastic syndrome. The objectives today that I'm going to cover include how MDS is defined as lower risk versus higher risk disease, and the discussion is going to be aimed at lower risk myelodysplastic syndrome. We'll talk about the basic clinical testing that's routinely employed for following the disease. And I'll also talk about treatment algorithms for specific abnormalities as far as hematological disorders that may be problematic in patients with myelodysplastic syndrome. And finally, we'll give an overview of some of the newer agents that have recently been FDA approved or are promising agents that are coming down the pipeline for treating patients with lower risk disease. So the initial piece that I want to talk about is how one classifies myelodysplastic syndrome, and this is based on the WHO classification. And there have been a number of different versions over the years of classifications of MDS, but this is the latest one. And so it classifies MDS into 6 different subtypes. And the first one is MDS with single lineage dysplasia, MDS SLD, where there's one dysplastic lineage. And what that means is when the pathologist looks at a bone marrow slides, he only sees one cell line in the marrow that's dysplastic. And these patients may have 1 to 2 cytopenias on their blood counts. And then the next one is MDS with multi-lineage dysplasia, and that's MDS MLD. And in this case, the pathologist sees 2 to 3 cell lines that are dysplastic, and patients have between 1 and 3 cytopenias in their on their blood counts. Now, you may notice I have noted in red some of the older ways of nomenclature for the classification. In other words, RA, refractory anemia, RCMDs, refractory cytopenia with multi-lineage dysplasia, but these are now changed to MDS MLD, for instance. So the next one is MDS with ring sideroblasts, or MDS RS, and in this classification, that one would see or need at least 15% of the red cell precursors having ring sideroblasts around the nucleus, and I'm going to show some pictures around that later on. Or they if they don't have 15% ring sideroblasts and only have at least 5% ring sideroblasts, if they have a mutation of this SF3B1 present, then one could classify it as this MDS-RS. And we will speak a little bit more about that. And then there's MDS with excess blasts, or MDS-EB, used to be called refractory anemia with excess blasts. And in this case, it's broken down into two subcategories: MDS-EB1, where there's 5 to 9% blasts in the bone marrow, or EBT, or EB2, where there's 10 to 19% blasts in the bone marrow. And then there's a group for MDS unclassified, where the pathologist is unsure exactly which category the patient's MDS conforms with. And finally, there's MDS with isolated del5q. And this is a specific cytogenetic abnormality which may occur alone, or there may be an additional other chromosomal abnormality other than a chromosome 7 involvement. So this slide shows the pie of lower risk and higher risk MDS, and you can see that the lower risk in orange is making up for 70% of all patients who are diagnosed with MDS. So it's much more commoner an event than is higher risk disease, which is notated in the blue. And patients with lower risk MDS have a relatively better survival. They have a lower transformation to developing acute myeloid leukemia compared to patients who have higher risk MDS. And the main clinical feature or challenge in these patients is the presence of anemia and the management of their anemia. So this slide just shows how cells are produced in the bone marrow. So we start off with a hematopoietic stem cell, and there's a limited number of these that we're born with and that are in the bone marrow, and they give rise to two different types of cells, the common myeloid progenitor or the common lymphoid progenitor. And I'm not going to really be speaking about the common lymphoid progenitors, but this side, these lymphoid progenitors give rise to lymphocytes of various kind that play an important role in immunity for us and preventing certain infections or dealing with certain infections. We're going to mainly talk about the common myeloid progenitor, which gives rise to the red cell progenitor in the middle, that then through a number of steps that are not noted on the slide, eventually will produce red blood cells that are in the marrow, and these red cells exit the marrow and enter the bloodstream. And that's where we get, when we test for anemia, for instance, we get a blood sample from the peripheral blood. Now, they also give rise to megakaryocytes, and again, there's a number of steps that finally lead to the development of platelets, and then they also give rise to the myeloblasts that will then, through a number of steps, lead to the production of neutrophils, basophils, eosinophils, and monocytes. All of these are found in the circulation, and they play an important role, at least some of them, especially the neutrophil, in dealing with infections, such as bacterial and fungal infections. And monocytes circulate and exit the bloodstream and go into tissues where they change into macrophages that have a whole different function in the body. So now, in patients with MDS, there may be some abnormality that hits the stem cell, and it's the computer, if you want, of the stem cell, the genes. And so it may cause some changes in cytogenetics or cause gene mutations, and then lead to the common myeloid progenitor also being abnormal now. It's got an abnormal computer, if you want, and this computer then doesn't work correctly, and so you get production of abnormal megakaryocytes or red cell precursors or myeloblasts, and eventually you'll get anemia if the red cell progenitor is damaged, and you'll get a neutropenia, which is a low neutrophil count, if the myeloblast is damaged, and then if the megakaryocyte is damaged, this may lead to development of low platelet counts, which is called thrombocytopenias. So once we have a diagnosis of an MDS, we want to try and see what's the prognosis that this patient will have. So this is the slide on how we make up or work out the International Prognostic Scoring System, revised. That's the R, stands for revised. In other words, this is a new version that allows us to calculate if the patient has lower risk or higher risk MDS. So when one has a bone marrow, you'll have cytogenetics done, and the cytogenetics will fall, and they take about a week to 2 weeks to come back. So, and they fall into really 5 different categories, from very good to very poor, and depending on the specific abnormalities that are seen in the cytogenetics. So, for instance, if they happen to have a score of intermediate cytogenetics, that would mean we'd count at 2. You can see in that column where intermediate is for cytogenetics, there's a number 2. So that would account for 2 scores. Now, if and then the pathologist will count the number of blasts in the bone marrow. So, and there's 4 categories that you can see for blasts going across along that row. So it may be less than 2 to greater than 10. So for instance, if a patient had between 5 to 10% blasts in the bone marrow, he'd have a score of 2 again. So if they had intermediate cytogenetics and intermediate blast and a blast count of 5 to 10%, then this person's score will be 4 already, before now looking into the hemoglobin level from the blood count, the platelet level, and the neutrophil level, absolute neutrophil count. That stands for the neutrophils. So, for instance, if the neutrophil count was below 0.8, there'd be an additional 0.5 added to that 4 score already. If the hemoglobin, let's say, was below 8, then there'd be a 1.5 added further to that. So that person would have a score of 6. And so we go to the next slide that then shows how we further classify this according to the score, the total score. So you can see lower risk MDS is noted in yellow, and there are 3 categories of it: very low, low, or intermediate MDS, and it depends on the score. So intermediate would have a score between 3, greater than 3 and 4.5. And in the very right-hand column is shown the survival, expected survival for a patient who has an intermediate risk score, which would be 3 years. So a median of 3 years, meaning that half the patients would have succumbed by 3 years, and the other half of the patients will live longer than 3 years. And so you can see this for each of these scores. And then in red is noted the higher risk disease, and you can see they have higher scores, and their survival is significantly different to what we see in the lower risk disease. So Now, as far as higher risk disease, these usually have the MDS EB1 or RAB1, where their blast counts are 5 to 9%, and RAB2, where their scores are even higher, their blast scores are 10 to 19%. And if there's 20% or more blasts in the marrow, we call that acute myeloid leukemia. So, as far as management of lower risk disease, the thing is, this may progress to develop higher risk myelodysplastic features. And because of this, we do the disease monitoring that I'm going to talk about now briefly. So one would get blood counts, and on a frequent basis, usually monthly. It could be that one needs blood counts more frequently, every 2 weeks, or maybe even weekly, depending on how severe the problem is. Or they may get blood counts every 3 months if it's very low risk disease. And same for the bone marrows. So I mentioned those were for blood counts. Now what about bone marrow? So they may need a bone marrow every 3 months if they have higher risk disease or intermediate risk disease, or a bone marrow may be done every 6 months if it's very low risk disease. So the frequency of these are done on the blood counts and the bone marrows depending on the state of disease and the blood counts, etc. And when one has a marrow, one will have cytogenetics done. One should also have flow cytometry done. And also in 2020, we'd hope that the doctor will order next generation sequencing looking for gene mutations, and which we will discuss later. And also, whenever a diagnosis of MDS is made, we also want to know what the iron status is. So patients should have a serum iron and a total iron binding capacity and a serum ferritin. They should also have an erythropoietin level done, and we're going to speak about these. And then also should have a vitamin B level and a folic acid level performed, and a copper level, just to make sure that this is indeed MDS, because sometimes these folate or B12 deficiency or copper deficiency can have features that look exactly like MDS does in the bone marrow. So now, as far as treatment is concerned, there are two treatment modalities that the doctor will think of: supportive therapy or disease-altering therapy. So as far as supportive therapy is concerned, this is given to help alleviate a patient's symptoms, make them feel comfortable, and not have a lot of symptoms such as, for instance, shortness of breath or fatigue, and try and help them with their daily quality of life features. Now, the disease-altering treatment is treatment to delay or halt the progression of the MDS, and try and prevent high-risk MDS from occurring, or if it does, to slow it down, its progress, and certainly to try and prevent the occurrence of acute myeloid leukemia, or at least delay the occurrence of acute myeloid leukemia. So this next slide shows a table of some of the common treatment options that are used more for supportive therapy in lower risk disease than for disease altering therapy. So first of all, transfusions, red cell transfusions. If a person becomes symptomatic, usually with a hemoglobin that's around about 9 or below, then in an attempt to improve anemia, you will receive red cell transfusions. And the problem with transfusions is, especially if it has to be given repeatedly, is that it has some negative effects on quality of life, having to go in to get a transfusion, which may last 4 hours of the day that one's at a center to get the transfusion. And repeated transfusions lead to iron overload. And iron overload causes certain organ damages and also and organ dysfunction and a whole lot of other problems that one has to deal with. And if the iron overload becomes fairly significant, then one usually will start on an iron chelation therapy such as XJade, for instance. Then there are other supportive measures at the bottom. If a patient has a low platelet count, they may need platelet transfusions. If they have a very low neutrophil count, the growth factors are given, and sometimes androgens are given. Those are testosterone-like drugs or derivatives that may help the bone marrow function to a minor extent. Then also on this slide is ESAs, which stands for erythropoiesis stimulating agents, and such as Procrit or Aranest, for instance, just two examples. Response rates are about 1 in 3 for patients who get ESAs, and the response duration is no longer than 2 years. You'd be lucky if one gets 13 to 2 years out of as a response with the use of these agents. Sometimes if they don't work, GCSF, that's a Neupogen, may be added to the ESA in an attempt to gain some efficacy. Now, then I also have on this slide lenalidomide. That's an oral agent. Its trade name is Revlimid. And usually it's used for patients who are red cell transfusion dependent, and especially for patients who may have the deletion 5q abnormality. And in those patients, one may achieve a red cell transfusion independence in close to 60% of patients. And then it's also used, but not FDA approved, in non-deletion 5q patients who red cell transfusion dependent. And in these patients, one may have approximately a 1 in 4 chance of becoming red cell transfusion independent, but the average time that may last is about 8 months, and then usually after that the response to this drug fails. So now an important note is, up till this year, there were no new therapies that were approved by the FDA or in Europe for MDS in the last 10 years. And only 3 agents were approved: 5-azacitidine, which is Vidaza, or decitabine, which is Dacogen, and lenalidomide, which is Revlimid. So another point of importance, so if a patient develops transfusion dependency, certainly of red cells as well as platelets, the prognosis is much worse. And these patients will have a greater risk of developing acute myeloid leukemia, and they have an inferior overall survival versus patients who don't require transfusions. Now, one important point that I have to make at this time is the importance of HSCT, which is hematopoietic stem cell transplantation or bone marrow transplantation. This is the only treatment that can potentially cure MDS in about 35 to 45% of patients, but it is not for all patients. In the US, one is able to get transfusions for their MDS up to the age of 75. But there is a risk of dying from complications of a transplant which is maybe up to 20% by the end of the first year after a transplant. So it's a balance that one has to make between risk versus potential cure in each patient, and there will be a talk on transplantation for MDS patients by one of my colleagues in a couple of months, I think. So now, what about gene mutation profiling? So I'd mentioned that when a patient has a bone marrow, ideally one should have next generation sequencing testing that's looking for mutations in genes. And this gives us an increased understanding of the biology of what drives MDS or why does it occur. And this is also gives us knowledge for treating patients. It may also allow earlier diagnosis. And you may have seen the term ICAS, which stands for idiopathic cytopenia of undetermined significance or origin, and more significance. So this is for patients sometimes. They have, let's say they're anemic and they cannot find a cause for the anemia, and the patient even has a bone marrow and they can't see clear features of MDS. But if you do the gene mutations on the bone marrow, you will invariably find abnormalities or mutations of genes that are causing the cytopenia, but the bone marrow doesn't show the clinical features when the pathologist looks at the cells that allow one to say this is a myelodysplastic syndrome. So it helps from that standpoint, and it also gives us a much more precise risk stratification. We'd mentioned the international prognostic scoring system, but if you have the gene mutations in addition to those, you're going to have a much better insight about the prognosis for the patient and help decide on treatment. So this has been studied at the moment and will likely be added to the IPSS-R scoring system. And so the mutation profiling gives us great promise for effective targeted therapies, and this is already happening. And if not yet achieved with targeted therapies, it's going to come, because knowing which cell lines are abnormal, in other words, the cell lines that control how a cell grows and functions, if we understand those lineages of how cells live, and understand if a mutation happens along that line or growth line, that gives us a better idea of what drugs to try and produce to correct those abnormalities. So just a short briefing on cytogenetics, and to point out that when cytogenetics are done, only 45% of patients with MDS will have cytogenetic abnormalities. That's noted in these colored slices of cake, if you want. And on the right, in blue, is that 55% of patients will have normal cytogenetics. But when one looks at mutations, virtually every patient will have a mutation. So nearly 100% of patients with MDS will you find a mutation, despite the fact that they have normal cytogenetics. So this is the importance of why we want to add this, looking for gene mutations to our armamentarium on patients' diagnoses. So what about treatment of lower risk disease? So once a diagnosis is made of lower risk disease, then the doctor is going to look at, well, is a patient symptomatic from his anemia? Is he short of breath? Can he not get through the day, etc.? Is he dizziness, lightheaded, or what? So that's one of the things. And if he's not symptomatic, he's got anemia and he's not symptomatic, they may just decide to follow the patient and not introduce any therapies yet, or maybe an ESA. So a patient may be thrombocytopenic or neutropenic alone, just isolated, or they may have a combination of any of these, which falls under the group, if you want, as pancytopenia. And we're going to discuss each one of these categories. So if a patient's symptomatic from their anemia, we want to know, well, what was their erythropoietin level? We should hopefully have an erythropoietin done and if it's below 500, then it's more likely that the patient will respond to an ESA, okay? And if it's greater than 500, the patient is unlikely to respond to treating them with an ESA. And so this helps us already put the patient into two groups. I'm going to treat this patient with an ESA or not. Now, if one treats with an ESA and it fails, or they respond and then fails, in April of this year, this drug, Luspatercept, was FDA approved, and we're going to speak about this shortly, but it's given as an injection every 3 weeks. And under the skin to try and stimulate red cell production. Again, we'll come to that. So if we have failure in this first step of giving an erythropoiesis stimulating agent or not, then the next thing we want to know from our bone marrow, and this is on the cytogenetics, well, was there a deletion 5q present? Or not? Was it a non-deletion 5q? If a patient has deletion 5q, we also would like to know, are there specific mutations, especially this TP53 mutation, that we know if that's there and a patient's treated with lenalidomide, it may hasten the onset of progression of the disease and perhaps even interfere and hasten the occurrence of AML. So if we're going to find this abnormality in a patient with deletion 5q, we're not going to treat them for too long if we're going to give them deletion 5q, and we're going to change to some other therapy or look for some other therapy. So normally we treat these patients with lenalidomide, as I'd mentioned earlier. Again, it's Revlimid. And usually one would see about close to 60% of patients will respond and become red cell transfusion independent, so they don't need red cells. And this may last for over a year to even longer, 2 years, if one's lucky. And then eventually, if it stops working and there's failure, then one will try HMTs, which stands for hypomethylating therapies, Dacogen, or which is decitabine, or Vidaza, which is 5-azacitidine. We'll go to one of those agents, and if we're not going to use those agents, or if we give them and the treatment fails, we'll have to go to experimental agents to try and find some study with some new agents that are being used. And so when they fail, then we're going to get back to red cell transfusion requirement. And before we even get to the use of red cell transfusions again, we should be looking all along from early diagnosis time about the possibility of doing a transplant for the patient. So the younger the person is and gets a transplant, the better, and the less disease and severity of disease there is, the better the patient will do with a transplant. Now, what about the patients who don't have deletion 5q? So we're going to, in these patients, we could try lenalidomide, but it only works in about 26% of patients who have non-del5q, and it's not FDA approved, so you can't always get it. Depends on the insurance coverage and their benevolence in allowing one to get this agent. And so, but 1 in 4 chance that one will respond. And unfortunately, response is only about 8 months before it will start failing. Now, and then if you don't use a lenalidomide, you'll use one of these HMTs again, or again, experimental agents will be considered for these patients. And again, you have to consider transplantation. For all patients, transplantation needs to be considered. So we move on to, well, what about refractory anemia with ring sideroblasts, or MDS with ring sideroblasts that we spoke about earlier on? And this is what they look like on an iron stain on a bone marrow when the pathologist looks at the marrow slides. And you see the cells with the dark red nuclei, this red staining. That's the nucleus of the cell. And you see the blue granules around the red nucleus. Those are iron. That's ring sideroblasts. That's what the pathologist looks like and counts how many of the red cell precursors have these ring sideroblasts, and they should be more than 15% to call it refractory anemia with ring sideroblasts. But remember, I'd mentioned earlier, if there's only 5% ring sideroblasts or more, 5 to 15% ring sideroblasts, and a patient has this mutation, SF3B1 mutation, then you can also fit it into this classification. So a little bit about this SF3B1 gene mutation, which is associated especially with ring sideroblasts in almost all of them of these patients. But if you look at all MDS patients, about anywhere from 14 to 28% of patients with MDS will carry this mutation. This is not, I'm not talking about the ones with ring sideroblasts. It's the others without the ring sideroblasts with MDS. And it certainly usually causes a pronounced defect in the erythroid lineage. So it interferes with how red cells are produced. And it's, however, when one has this, especially if it's the only mutation, then it's usually has a very good prognosis. It tells us, hey, this MDS prognosis is good. But it also, they often are associated with other gene abnormalities as well. And depending on the other gene abnormalities, that also may give us an idea if this is really still going to be associated with a good prognosis or not. So now we're going to talk about this agent Luspatercept. Its trade name is Reblozyl. As I mentioned, it was approved by the FDA in February. And this slide just shows all the steps from, on the left, the stem cell in the bone marrow and along this production of red cells. And it takes about 10 days from this BFUE stage to development of red cells in the bone marrow. It takes about 10 days for that maturation to occur. And these cells go through all these steps. So there's a stage where these cells may be erythropoietin dependent. So and then it's fairly early on in how the cells are differentiating towards red cells, mature red cells, and one loses the efficacy of the erythropoietin when the cells become more mature and start becoming terminally differentiating. And this is the stage where Reblozyl has its efficacy in this very late stages of differentiation to a red cell. So it works at a different stage on red cell production in the bone marrow from erythropoietin. And so there's FDA approval was really based on this medalist trial where they randomized patients 2-to-1. 2 patients received Luspatercept, again, given as a sub-Q injection every 21 days, to 1 patient who was given a placebo injection every 21 days. And these patients were specifically studied who had MDS with ring sideroblasts, as we'd been speaking about earlier on, and they had to have lower risk disease, so they fall into that category. They had to be receiving red cell transfusions at least 2 or more units every 8 weeks, and they should have failed to respond to an ESA, to erythropoietin treatment, or they had a response and they lost their response, or if they had an erythropoietin level greater than 2, they didn't have to have prior ESA treatment, because when you get over an erythropoietin of 200 to and certainly over 500, the response to these agents, ESA agents, drop off significantly. So this is the results from the study in patients with lower risk disease. And I'm going to just go over this. The blue histogram is for patients who were treated with Luspatercept, and the orange is for patients who received placebo. And so in this first left-hand histogram, it shows that 38% of patients who were treated with the drug had at least more than 8 weeks or more period of being red cell transfusion independent within those first 24 weeks of treatment. So somewhere in the first 24 weeks, or about 6 months, 38% of them became red cell transfusion independent. That lasted for at least 8 weeks. And when they looked at, well, how many had greater than 12 weeks of transfusion independence in that first 24 weeks, 28%. And then they looked at, well, in the first 48 weeks, how many of them were transfusion independent? That lasted at least 12 weeks, and you can see here 33%, or about a third of patients, have transfusion independence that lasts at least more than 8 weeks in the first close to a year's period of time. So this was the main features that led to the approval of this agent. And also in the study, they showed that the hemoglobin increased by at least 1.5 grams per deciliter over their baseline level in 63% of patients, and 48% of patients had a reduction of by at least by more than 4 units of red cells per 8 weeks. So those who were heavily red cell transfusion dependent, 48% of them had reduction by 4 units from what they were receiving before coming onto the study. So it has really good potential. Now we're going to change and talk about thrombocytopenia. So if a patient's platelet counts drop below about 150,000, we call that thrombocytopenia. And when the platelets get below 50,000, we're starting to get into trouble. And when it gets below 20,000, that's more significant problems. And we certainly don't want platelet counts below 10,000, because they're going to likely bleed spontaneously. And gum bleeds, nose bleeds, bruising, petechiae. So bleeding in the bowel, bleeding from the urinary tract, so problems with bleeding. And so when we have thrombocytopenia, we'll usually choose to give hypomethylating agents again, but it doesn't work for all. Maybe 20 to 25% of patients will have a response. We use platelet transfusions if the platelet counts get below 15,000 usually. Some use a platelet count of 10,000 or below. And the problem with platelet transfusions is one may become allergic to them in a way and develop certain allergies, or not respond to the platelet transfusions. You get antibodies to the platelets and break the platelets up that are transfused in, and it may happen fairly rapidly. So they may not last long. So then one has to think of experimental agents, and then one should consider if one can get approval from, again, the insurance companies to use one of these agents, Promacta, which is L-Trombopag, or N-plate, which is Romiplastin. Promacta is tablets, N-plate is infusion of treatment, and these are known as thrombopoietin mimetics. They stimulate a certain receptor on the megakaryocyte to produce platelets. It doesn't work for all, and one of the problems with the use of these agents is that the blast count in the bone marrow may go up. So when these agents were used initially, they saw increasing blasts and thought that these agents had could produce acute myeloid leukemia at an earlier stage, and therefore when you're getting treatment with one of these agents, you certainly should have a bone marrow every 3 months to make sure that there's no leukemia occurring. Again, transplantation should always be a consideration for these patients. Now, what about patients with severe neutropenia? So neutropenia as an isolated presentation in MDS is fairly uncommon. It's about a 4-5% entity, and the thrombocytopenia is about a 10% entity as presenting alone as a presenting feature. And the anemias account for about 85% of all the presenting problems. So now if one has severe neutropenia, and that's a neutrophil count that's below 0.5 or below 500, that is bad, because it gives one an increased risk of infections, and one may even get febrile neutropenia. One may get fevers without any obvious infections that can be detected. So if one has this very low count, then one should go on to prophylactic antibiotics, antifungal agents, and antiviral agents to try and prevent infections from happening or control any infections that may already be on board in a patient. And so one would usually use GCSF, Neupogen, for instance, to try and see if this will push up the neutrophil count. It doesn't often work for most patients, but there may be a small 10 to 20% of patients that may respond to the administration of GCSF. Again, then one may have to use hypomethylating agents, and it doesn't work for the majority of patients. Maybe 10-15% of patients will have a response to a hypomethylating agent. So you always have to try and think of a transplant for these patients. Now, what about patients who have pancytopenia? In other words, there's more than one abnormality on the blood count. Anemia, maybe platelet counts is also low, maybe all three are low. And in this situation, the bone marrow is going to help at least as for this first step. So if we have a younger patient and their bone marrow is hypoplastic, meaning that there's not a lot of cells in the marrow, the cells that are producing the peripheral blood cells are really reduced, and there are no increased blasts in the bone marrow, and the cytogenetics are normal, then we're going to do an HLA typing and looking for this HLA DR15. HLA stands for histocompatibility antigens, and this is the testing that one does to try and look to do a transplant to match a patient with a donor's cells. So we'll do that, and if this HLA DR15 is present, they're likely to respond to immunosuppressive therapies to suppress the immune system of the patient, their lymphoid system, with anti-thymocyte globulin, that's the ATG, and cyclosporin or cyclosporin-like derivatives, that these agents are used, again, in treating patients who have a transplant to prevent rejection of a transplant, for instance, and sometimes certainly used for graft versus host disease. So it's to switch off the immune system in these patients. and so you may get responses. But we also may have to try HMTs again, and again, you're going to rely on stem cell transplantation. The sooner you can do a transplant, the better, again, before the disease progresses to a worse level or state. So just a few words about the HMTs, azacitidine or Vidaza, and Dacogen. It's important to know that one should administer at least 4 to 6 cycles of therapy before one can decide whether this is working or not. Because usually with the first 2 to 3 cycles of therapy, one will see a decline in the blood count. So you think, well, the disease is progressing and this is not helping. No, it's usually that these agents will cause the cytopenias in those first 2 to 3 cycles. And usually after that, after the first 2 cycles, or maybe 3, you may start seeing responsiveness. So important again, try and obtain 6 cycles of therapy. So I'm now going to talk about another new agent that was recently FDA approved, Inqovi. Its study name was ASTX727. And so if one gives decitabine, Dacogen, or Vidaza by mouth, it is broken down in the gastrointestinal tract by this enzyme cytidine deaminase that's not only in the gastrointestinal tract, but it's also in the liver. And so it breaks these agents down so that they become only inactive. So what they did was add this agent cedazuridine, which inhibits the cytidine deaminase from breaking down the decitabine. So this agent is decitabine combined with cedazuridine, it's tablets. And so it was approved a month ago by the FDA, but it was approved for patients with higher intermediate and high-risk MDS or patients with chronic myelomonocytic leukemia. And in this study, there was a 1-to-1 randomization to sequence A, which was given the oral agent, and then in cycle 1, in cycle 2, they were given intravenous decitabine. And they were comparing the absorption of the oral agent to giving the drug intravenously. And in sequence B, it was just giving it in an opposite first IV decitabine and then the oral agent. And then after the 2 cycles, they could go on to with the oral agent and be treated with that. And this approval was based on this slide, where in green here on the right is the absorption characteristics of the individual patients on day 1 and day 5, when, in what you'd see with intravenous Dacogen in the blood, and the absorption characteristics on the left in blue of when they gave this oral agent Aztec 727. And you can see the absorption of these two are virtually identical looking from day 2 to 5 for the oral agent. And this is why it was approved, because Dacogen was already approved. So they showed that you could get the same levels of drug in the bloodstream by taking this agent orally. So, and it had certain responses, and the main response I want to talk about, because again, a lot of the patients were high risk disease, but the intermediate risk was also included. And remember that intermediate risk MDS can fall into lower risk disease. So a patient with lower risk disease but who has intermediate level of disease should be able to get this treatment. So as far as red cell transfusion independence, so there were 52 patients who were requiring transfusions, and after treatment with this drug, about a third of them became transfusion independent. That's for the 8 weeks. And then also I want to mention for platelet patients who were requiring platelet transfusions. There were 10 of them, and 3 of the 10, or 30% of them, became transfusion independent of platelets. So good responses, at least reasonable to use in patients with lower risk MDS. And the final treatment I'd like to discuss is, and this is coming down the pipeline, it's in its infancy, but it's this drug imetelstat, and there's a phase 2 study has been completed and phase 3 studies have started in transfusion-dependent patients who've relapsed to or are resistant to erythropoiesis treatment. So this is a randomized study 2-to-1 again that's starting and so it should be available at certain centers. But I'm going to talk about the results they saw in 38 patients in this phase 2 study that was presented at the European Hematology Association meeting in June of this year. And I'm presenting it because it seems to have some hopeful efficacy that will and that it will become available for our patients. So in their patients who were red cell transfusion dependent, transfusion independence lasting 8 weeks was seen in 42% of patients, and some of them were going on at 88 weeks after achieving the independence. And if you looked at patients who were looked at for red cell transfusion independence lasting at least 24 weeks, that was 32% of them fell into this category, and 68% of the patients had an improvement in their hemoglobin level. So it's a new drug with some hope that these results will continue in the phase 3 study, and it will also become available. So I think in the past year, we've had 2 new agents that we can use for patients, and we have some other agents like this, the imetelstat, that hopefully will become available and have positive results in this phase 3 study for use in our patients. I'm going to stop here and take questions.
We have our very first question in from Elizabeth. Her father has low risk MDS, and his white blood counts and neutrophils have been particularly low in recent weeks. They are running at 500. Should he refrain from getting a flu shot due to his low blood counts?
Yeah, it's a good question. So, at that level, one is extremely prone to getting infections. And I would say, flu shots, they're not live viruses, or we call it live attenuated viruses. They should not be live. And so I think it would be fine to have a flu shot. It may not work as well as if one was given a flu shot when the blood counts are totally normal, because the immune cells, when you have a total white count that low, it means the lymphocytes and the neutrophils are low. And you need especially the lymphocytes in this situation that help make the antibodies. You get the flu shot, and then your immune system will react to it and produce the antibodies, and also stimulate other lymphocytes. There are 2 sets of lymphocytes, if you want. There's B lymphocytes that make the antibodies, and then there's T lymphocytes that also get stimulated to look for viruses, and if they see them, if you want, I'm just simplifying it, they would kill or attack the virus and try and annihilate the virus, if you want. So we need both systems, really, especially for flu. So you may not get as good a response as one would have if you had normal blood counts, but still you may get some benefit from it. And I'd certainly consider doing the flu shot. And then, maybe one should consider repeating it, by the end of the flu season again, just to bolster the immune system. And hopefully at that time, there'll be better recovery of the lymphocytes, if you want, so that if you repeat the vaccination, you'll get a better response from the second injection. So yes, I would certainly take a flu shot. And one question I would put is, do you know, was this drop or this low white count, is that on treatment or without any treatment that would have induced the count to drop? That would be one question that's also would be helpful in understanding. So because again, when we use hypomethylating agents, for instance, or even a drug like Revlimid, one's likely to see some decline in the white counts themselves, especially the neutrophils with the hypomethylating agents, not so much the lymphocytes, but the neutrophil counts. So I hope that helps with that question.
Thank you for your very thoughtful and thorough answer. The next question is from a patient who was diagnosed with MDS, RS, MLD. They want to know if this is a combination of the two that they should be paying attention to. They were diagnosed 14 months ago, no symptoms, stable blood counts, just the platelet count is being affected, down around 90. Their ring sideroblast, 15.5%, isolated trisomy 19, and a pathogenic mutation of SRSF2, had prior radiation therapy for breast cancer.
Okay, so yeah, so yeah, the MDS with the MLDRS. So this is the one subtype that we spoke about. It's not with a single, if you want, cytopenia, but or one or two cytopenias. Usually, when you have the MLD, mixed lymphocyte dysplasia, they're seeing more than one cell line that's dysplastic in the bone marrow. And so now, if a person had prior radiation therapies, that could have helped initiate this disorder. And unfortunately, some of the chemotherapies and radiation therapies that we receive for other disorders can help initiate or be responsible for initiating MDS in some case in some patients. So it's good that the platelet count's at 90,000. That should not cause any problems. And one can receive most surgeries, with a platelet count of about 90,000. So from that standpoint, that's good. Having the SRSF2 it helps us. It's a less common gene mutation that we'll see in overall MDS patients. We call it a spliceosome gene, if you want. It's in the same sort of area that you'll see as the SF3B1 mutation. It has a similar job that it does, the protein that's produced from that gene. And then there's the trisomy 19 abnormality. So if a patient, with this disorder, I would certainly, if one's below the age of 70, 75, one of the things to consider for the future, long term, maybe in 2, 3, 5 years' time, is to see if one, consider transplantation in case the disease progresses. It's more likely to progress than just remain stable, but it could take some years to progress. Because, you know, with the IPSS-R score that you'd have, that it's, if your neutrophil count's normal and there's no hemoglobin level, let's say below 10, and it's just the platelet count that's low, the score is low that you'd have, so, but you know, it could progress over time, and you know, just keep that in mind. You know, should one consider at some point having a transplant should the disease progress? And I would have, you know, certainly have, if I were looking after one, I would probably get a bone marrow on a patient like you every 4 months, and you know, and do not only do the cytogenetics, because we want to see are there any new cytogenetic changes occurring, but also I'd like to see, are there any new gene mutations that are occurring as well? And should we see that happening, then I would consider, you know, going towards a transplant earlier rather than later. So that's just one thing I would do, you know, keep in mind to do. And it's reasonable to not start any treatment at this point. Now, you know, the drug Luspatercept, should, you know, anemia start happening, I'd certainly maybe try and get that as one of the initial treatments. But at the moment, I would agree, don't do any treatment at the moment, but just consider, you know, follow-up is most important to look for evidence of disease progression early on. That's with the mutations in the cytogenetics. And to do that, you have to do the marrows, so that one could then sort of start treatment, specific treatment, disease delaying treatment, if you want, that we spoke about earlier on rather than later. So I hope that answers that question.
Wonderful. Thank you, Dr. Skickney. The next question comes from an MDS patient, transfusion dependent, requiring transfusions every 10 to 12 days, does not have ring sideroblasts. And her question is, when using Luspatercept, how long before improvement is seen? And what are side effects in some of these patients?
Yeah, good question. So here's the thing. It may take anywhere from up to 6 cycles to see a good response, but usually you'll start seeing a response within 6 cycles. So you get the shot every 3 weeks. I would at least try and do 6 cycles. Now, one important thing is, you know, the standard is to start at this 1 milligram per kilogram dose, and maybe if one's not seeing any response after two injections, in other words, after 6 weeks, I would then consider to get the bigger dose of 1.75 milligrams per kilogram injection. So some patients do require the bigger dose, so you have to tighten the dose. Perhaps in the ideal situation would be to start at 1.75 milligrams if the doctor will do that. And then if you're having a great response, then maybe one could cut the dose down slowly to see, and as long as it's maintaining a stable hemoglobin. But 6 cycles is what I would say one should do. And you don't, you know, the interesting thing about this is those studies that were done in the medalist trial was for ring sideroblasts. So it works in patients who don't have ring sideroblasts as well, not as well as patients who have ring sideroblasts, but you can expect to have a good response, a fairly good response with the injections, even if you don't have the ring sideroblasts at all. That's the one thing. And another interesting thing, point to make that I think is really something unique about this drug, as opposed to erythropoiesis stimulating agents, erythropotens, where we know if you have a high erythropoietin level, let's say at 500 or above, it's, the chances of response are really slim, less than 10%. When one uses Luspatercept, there's about a 40% chance that one's going to respond, even though the erythropoietin level is greater than 500. So there are ongoing studies around this, but from the initial trials, they saw some of this happening. And just one other point of interest. That is, and it needs further evaluation, if you want, is that some patients who had neutropenia as part of their MDS, when they were treated with Luspatercept, had some improvement in their neutrophil count. So it may have more efficacy than what we, that as far up to, from what we know at this point in time. So that's just some points of interest around that. So yes, I would certainly stick with it and try. Hopefully you'd have at least a 40% chance of responding to it. But you may want to try at least six injections if you want. I hope that answers that.
Thank you so much. The next question comes in from John, who is an MDS patient with MPN. He wants to know, what is the frequency of patients having this?
Yeah. So frequency. So it's not as frequent as patients with the MDS itself. And so it's an overlap syndrome. So maybe for every 10 patients with MDS that we see, we may see maybe 2, maybe 3 patients with this overlap syndrome, where there's features of MDS and myeloproliferative neoplasms. And I'm not sure what treatment you're receiving, but yes, so I think that answers your question on that. But yeah, so it's not as frequent as straight MDS, but yeah, maybe for every, in other words, 3 patients with MDS, 3 to 4 MDS patients, we may see a patient with this overlap type syndrome. And sometimes it takes time. A patient may start off with a myeloproliferative neoplasm looking like disorder, and we don't see MDS features. And maybe in a year or two's time, the MDS features start appearing. So they don't always happen right at the same time straight away together. So I hope that answers that one.
Thank you. The next question comes in from Elizabeth. In MDS patients, have you seen problems when kidneys stop producing erythropoietin?
Yeah, so here's the thing. One should always, so let's say you have it's a really interesting point. And while you were talking about that, I'm going to come back and help answer the question about Luspatercept and the side effects. But so you should keep an eye on renal function in any patient with MDS who's getting treatments. They may be getting antibiotics. It's important in that as we get older also, our renal functions aren't as good as they were when we were younger. So as we age, maybe the kidneys start producing less erythropoietin. So maybe at the beginning of the MDS diagnosis, kidneys working well, making adequate erythropoietin. And maybe in 2 years' time, you've had an infection, a kidney infection, or you've had infection with antibiotics, and you may have sustained some renal damage or dysfunction. And then again, just getting older, the kidneys are not working as well. So, and that erythropoietin levels may drop off. So it is worthwhile, and it's a really good thing to ask the doc if you're having problems with anemia and responses to treatment, could they check your kidney function and maybe think of checking, do you have enough erythropoietin being produced by your kidney? Because that does happen. And so that's a really good question. And sometimes doctors forget that, you have a good kidney function and you measure the erythropoietin, but 2 years later it may be totally different, and and it's certainly worthwhile rechecking it. So if you have anemia and erythropoietin, let's say one has a hemoglobin that's below 10, let's say it's 9, you'd expect the erythropoietin level to go up to at least close to 100. The normal is about below 20, about say 10 to 20 is the normal sort of level that you'd expect. But if you're anemic, the kidney should respond to that by producing more erythropoietin, and the level should be at least close to 100 or more. And that's why we see a lot of patients with myelodysplastic syndrome. They come with a hemoglobin, let's say around about 8. Their erythropoietin levels may be 500. That's an adequate, good response. So I hope that answers your question. But I want to go back to the question about the Luspatercept and the side effects. They are, you get injections, a subcutaneous injection, and there's really not more than 10% symptoms that have been reported, and certainly no severe symptoms, significant symptoms, maybe fatigue in 8%, 10% of patients, but that's it. So it's a good drug to use, and it has minimal effects.
Thank you, Dr. Stickney. Next question, what percent of lower risk MDS patients move from observation to treatment? Also, does the TET2 mutation impact treatment if needed?
Okay, yeah. So most patients eventually, let's say we have 100 patients with lower risk disease that we are observing. And let's say we look 4 or 5 years later, probably 60 to 70% of them will be getting some treatment. So some patients may have a very long time, maybe 7, 8 years, and not require any therapy. Maybe they'll have a slight decrease in their hemoglobin level. Let's say you start off with a hemoglobin of 13. And if it slowly drops, let's say a gram a year, so to 10, you may not have symptoms or feel the hemoglobin of 10. Usually one's fine at a hemoglobin of 10. And especially when the hemoglobin level drops very slowly, the body accommodates to it. And there are different mechanisms that happen that tune your body up, if you want, to accommodate for that drop in hemoglobin. So, but when you get to below a hemoglobin of 9 to 8, that's when the symptoms really start. You start feeling that with fatigue, shortness of breath, etc., just lack of energy. So now about 60 to 70% in 5 years' time are going to require some form of therapy. You're starting off with observation. Now, as far as the TET2 mutation, that's an interesting question. If it's a single mutation, it is really an interesting question, because if we look at a normal aging population, over the age, let's say, of 55 to 60, and we're going to see the incidence of TET2 mutations going up. There's some other DNMT3 is another gene that is mutated as we age. So there may be patients who harbor mutations, or people who harbor mutations but never ever will develop a problem from it. So there's CCUS. That's a term we use for that, where there's no cytogenetic, there's no hematological abnormalities, but we carry these mutations, especially as we age. And so nothing may ever happen because of that mutation. And unless somebody's already has some kind of anemia that's present. So it may be meaningless if it's just there by itself. It would be, so if one is a patient like this, you have a TET2 mutation, no symptoms, you've been observed, and minimal cytopenia, I may, depending on what the blood counts are doing, and if a cytopenia is progressing, I may only say, okay, I'd say, let's do a bone marrow on a yearly basis and check and see what's happening with this mutation. Is anything new? Is there a new chromosomal change happening? But I may still not treat a patient until they develop a problem with blood counts, that, you know, at a level where we have to intercede with a treatment. Because one may go on for many years like this without anything happening that requires treatment.
Thank you, Dr. Stickney. Next question from Phil. What do you think of the supplement Osteo-K for low-risk MDS?
Say again, Oxy?
Osteo-K supplement?
Okay, I have no, I'm afraid you got me on that one. Osteo-K, I don't know anything about that. It's a supplement. Do you know what it contains? Does the, because I'm not sure, I cannot answer that.
That's fine. We can look more into it, Dr. Stickney. We'll skip on to the next question, but thank you.
Yeah, I could look that up and get back to, so we can answer the patient's question. You know, I want to know what it contains.
Perfect, sounds great. The next question is from Michael. Is there a relationship between low-risk MDS and polymyalgia?
Between low-risk MDS and
polymyalgia?
Polymyalgia.
Yes.
Okay. So here's the thing. You know, it's a really interesting and good question, and we don't often talk about it. And you remember today, and we just mentioned the lymphoid system. So a number of patients with myelodysplastic syndrome may have actual abnormalities that involve the lymphoid system. And so the polymyalgia rheumatica may be a disease, an autoimmune type of disorder. And so a number of patients with MDS may have associated autoimmune type disorders, and there's certain receptors, they call them, for instance, there's a system called TOLL, T-O-L-L type pathway or system, the toll-like receptors and system that switch on immune reactivity, like as if you have a cold or a flu. And so some patients with MDS may have these symptoms that feel like, hey, you almost feel like you got flu, and it's not because they're anemic or their white count's low itself, or any of their blood count changes. It's related to the immune system being switched on in a dysfunctional way, if you want. And yes, there may be an association between polymyalgia rheumatica and the low risk MDS. And so, you know, one could look at the there are some studies, and people are starting to realize this more. And there are some studies looking at, you get these cytokines and what they call chemokines. They kind of hormones, if you want, but they're bad reacting hormones that get switched on. I'm just making it simple. They get switched on to similar to, and you have symptoms that feel like you got a cold or flu. You just feel lousy, if you want. Yes, so that happens in some patients, and certainly one may have an increased risk of arthritis type symptoms in patients with myelodysplastic syndromes, for instance. And then even with patients who have autoimmune, with let's say anemia, some patients may develop an autoimmune, an immune reaction against red cells as well as the MDS. So you can get autoimmune hemolytic anemias, autoimmune thrombocytopenias, and autoimmune neutropenias, and autoimmune sort of red cell aplasia. There's a disease, pure red cell aplasia. So as part of the MDS, sometimes there's more to it than just the bone marrow not producing cells, but there's also increased destruction of cells that are happening because of antibodies that are produced against the cells in our blood, or even the T cells, that other system, that there's killer T cells that come along, and they may attack and cause a problem as well, and help destroy cells that are circulating. So that's also part of an immune system dysfunction that can happen in MDS. Again, we don't always look for it because it's not the frequent occurring thing, and maybe in 10 to 20% of patients that these type of reactions happen. There's also been reports of peripheral neuritis, where one loses sense. You get sensory changes in the nerves, especially in the lower extremities. That may be associated with MDS. So yes, there are these uncommon disorders that may be associated.
Thank you. That's all the time that we have for questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.